Good afternoon. Oh, it worked. Welcome, everyone. We're so excited you're here. Want to welcome our panelists, first of all. We'll introduce them later on in the program. I want to welcome all of you who are here at the Dreamland. And I want to welcome all the people who are watching from wherever on Zoom. And I especially want to welcome our sponsors. You'll see their names in a few minutes. I'm proud to tell you that we have over 60 sponsors from this, for this event. And I can thank my co-hosts and all of our committee for the yeoman work they did to bring so many people here. Even though it's a sold-out event, it doesn't look like it. But I'm actually glad that there's a lot of seating because then it gave us the option to have people sit where they were most comfortable. I think we would all agree that it's been a very challenging time for practically all of us. I'd like to see a show of hands of people who've used the hospital in the past, say, 18 months. Okay, take a look at that, Gary. That's a very large number. Leave your hand up if you used the hospital for either a COVID test or for a vaccine. Okay, I'm glad to see that. Anyway, the point is that Nantucket Cottage Hospital has been here for all of us. They've just been there for us in whatever way we need them in the past 18 months and even longer than that, but just during this very difficult time. And today, I'm proud to say, we're here for them. The pandemic has kept many of you from your annual screenings. Perhaps you or a friend or family member postponed your routine checkups. Or maybe you didn't follow up on symptoms that you experienced. We hope today to change that. As we say every year, women make 80% of healthcare decisions. You are your family's medical advocates and the ones who organize care for your loved ones. Today, we're addressing the importance of detecting cancer in its earliest stages, and we're encouraging you to take advantage of the existing early detection capabilities, both here on Nantucket and in your local venues. You'll hear about the latest and most exciting new technologies for screening. Early detection saves lives. It saved mine twice. Some of you know my story, but for those who don't, I don't know if you can see it, but I have an angel sitting right here on my shoulder. In 2005, I found out I had lung cancer. It was a huge surprise, and it was an accidental finding. I went to the ER for chest pain, which turned out to be a pulled muscle from Pilates. Nothing serious, but it took me to the ER. The ER doctor, who was a woman, said to me, "Meryl, you've never smoked. I doubt if it's anything, but you need to get this checked." So of course I did. And when I had the CAT scan, it showed that there was nothing on my left lung. It was a shadow that they had seen in the x-ray, but there was a tumor on my right lung. So I had surgery, and then I had chemo. And this was again in 2005. And then again in 2012, I had a recurrence, and this time they found it even earlier, and I only had surgery. As a lung cancer survivor and advocate, I met Dr. Sequest when she was a young investigator. To me, she's still a young investigator. She's been a thoughtful and caring clinician. I've sent her many patients over the years, and she's been there for them every step of the way. Now, she's director of the Center for Innovation in Early Cancer Detection, and she's at the forefront of research on finding cancer with new technologies. Since my diagnosis, lung cancer, like other cancer, has incredibly advanced treatments. You've heard all the ads for Opdivo and Keytruda. So now there's something called immunotherapy. There wasn't any of this when I started my journey. And now there's all kinds of things that the doctors have a much wider toolkit. So if they can find cancer earlier, they can save lives. After Dr. Sequest, you'll hear from two of our own. They're part of our oncology team here at the hospital. Gretchen Bookman and Ugna, she'll pronounce her last name for you. We are lucky to have such caring and competent professionals on this island. And then we can all relax, okay? I know I need it. I bet you do too. We're delighted that Rayna Chadnovsky, sitting right here in the pink, she's here today, and she's from the Benson Henry Institute, which is also at Mass General, and she'll be sharing positivity and relaxation techniques. I was hoping to say post-COVID, but now with its resurgence, it's exactly what we need. Before we hear from our speakers, I want to say a number of thank yous. First, thank you to my co-hosts sitting here in the front row, Karen Dougherty and Mary Tafe. To our extraordinary host committee, at some point you're going to see their names. They brought in, as I mentioned, over 60 sponsors. To our valued sponsors, and you'll hopefully see their names as well. And then I want to thank the hospital development team. There are a bunch of people who stepped into the fray, most of them brand new, and I want to make sure they get their thanks. I want to say a special thanks to two people. One is Lisa Clary Lawler, and the other is Joanna Roach, and you both know why I'm thanking you. And I want to thank my fellow co-founders, Janine Borthwick and Melanie, who you'll meet later today. Now it's my honor to introduce you to the person who works day and night to keep us safe. As far as I'm concerned, he's a rock star. His name is Gary Shaw, and he's the CEO of Nantucket Cottage Hospital. Please give him a warm welcome. Gary deserves that and a lot more.
Thank you so much.
You're welcome.
Well, it sure is nice to be partially able to go to a mask-free environment, and I wish we could do that tonight. But what an honor to be standing in front of so many co-leaders in healthcare with what we were told about how women make so many decisions moving healthcare forward. It's quite an honor to be here and to be able to learn much about the next generation of what we're going to be doing and where we're going. Before I do that, though, I would be remiss if I didn't say thank you to Mary Braylauer for all of the hard work that she's put into bringing this all together with all of the teams and committees, and for that, we wouldn't have a dynamic event as we have this evening. So if we could give a round of applause to Mary. I intentionally wanted to keep my remarks short so that we could put the focus on what this gathering is all about, and that's moving into the discussion that's on the agenda today. But I just want to leave a teaser. I know we're going upstairs to talk a little bit in a while and mingle. At the Cottage Hospital, one of the things we're focused on, and we're focused on through COVID, although we were trying to lean into just doing things in the town and vaccines and PCR testing, we started talking about our strategies moving forward. And we have a very solid focus on creating a new program that we're calling the Lighthouse Whole Person System of Care, and that focuses on mind, body, and spirit. So I'd love to be upstairs, talk to you about it. It is a design that will be focused on measurably improving the health of a community, and it starts with nurse practitioners and your access through the care continuum of primary care involving mental health and other things that we're working to bring in solid, sustainable ways to the community. So that's the teaser. Thank you for this opportunity to come and be part of a gathering that just hasn't happened in more than, 2 years. And so I wish you well on this conference today, and I'll turn it over to the next agenda speaker. Thank you so much.
Clunky shoes, sorry. Okay, taking a deep breath for my stress. Good afternoon. I'm Karen Dougherty and so delighted to be involved with such a special event. Thank you, Melanie and Meryl, for this great honor. When Meryl asked our committee who would like to introduce the speakers, I can assure you my hand did not go up. But here I am. I'm going to pay close attention to the stress relief techniques later that we hear in the program. Let's get started. Our first speaker is Dr. Alicia Sequest. Originally from Michigan, same. She received her MD from Harvard with a stopover at Cornell University studying chemistry. She joined the Mass General family in 2005 and will be sharing with you the newest technologies and latest development in cancer detection. Dr. Sequest is the director of the Center for Innovation at MGH. Dr. Sequest also has a second career, that of hockey and dance mom. Her son Gabe, who is with her today, is a hip-hop dancer extraordinaire. He's on the Celtics junior dance team and has performed numerous times at the TD Garden. Way to go, Gabe. Our next two guests, here we go, Ugna, I learned it, okay. Ugna and Gretchen will be discussing cancer screening, the cold cap therapy, and specifically what we offer here on island at the hospital. Both ladies are on the oncology team and the Nantucket Cottage Hospital. Ugna is an NP, so is my daughter Margot, just last month, and is the program leader for hematology and oncology. In her spare time, she co-founded Lavender Farms Wellness Center. It offers a variety of health services, and I, for one, look forward to checking that out. Fun fact, she biked across the Himalayan mountains from Lhasa to Kathmandu. Wow, crazy. I mean, didn't you all want to go to Kathmandu when you heard that song? Love it. Okay, and Gretchen Bookman is the clinical nurse leader for Infusion and Cancer Center. She manages the daily operations and serves dozens of Nantucketers impacted by cancer. Gretchen is a 16th generation Nantucketer, and both her great-grandmother and grandmother were also nurses. So wonderful. She also leads the Nantucket Hospital Swim Across America team and has participated every year and helped raise tens of thousands of dollars for NCH. This year, 190 swimmers participated, and they have raised more than $436,000. That's awesome. And finally, our last speaker, Rayna Chadnovsky. Rayna is the director of the Education Initiative for the Benson Henry Institute at MGH. Her topic today will be sharing techniques on stress relief and positivity. I am still here, Rayna, and still needing you. A cute story about her. Apparently, back in middle school, she and her girlfriend's favorite band was the Beastie Boys. She even named her girl group the Beastie Girls. I just heard Ad Rock and Mike D, for those in the audience who don't know who those are, they're the last two that are left of the Beastie Boys. They're looking to start up again, Rayna. So there's still time for a career change. In closing, there will be a question and answer time hosted by my co-chair, Mary Tafe. So please hold all questions until then. And without further ado, please welcome Dr. Alicia Sequest.
Thank you. Those were great introductions. You did a great job. It's really a pleasure to be here and to spend a little bit of time on Nantucket with my son, too. We had a great time yesterday and today. So I couldn't agree with Meryl more. One of the things that has been impacted during the COVID pandemic is screening for cancer. And screening for cancer is so important. As Meryl discussed, when cancers are detected early, it can help save lives. But I'm going to talk to you today about that. You're getting an introduction to epidemiology and statistics and some of the issues we think about in cancer screening. And then I'm going to talk to you about the future of screening and all of the things that we still have to do better, and what I'm really passionate about. So I'm also a medical oncologist, so I treat patients with active cancer. My field is lung cancer, and I'm going to talk a lot about lung cancer today because I think that, especially in a female audience, we don't always hear about lung cancer. We hear a lot about breast cancer, and lung cancer, I think, is something worth knowing about if you don't know anything about it. So these are pictures of the lungs and talking about how cancer is categorized in different stages, but this doesn't have to be lung cancer. All different kinds of cancers, breast, colon, prostate, all cancers are categorized in a similar stage, 1, 2, 3, and 4, where essentially stage 1 is the earliest tumor. In this drawing, well, I don't know if I'll use the pointer here. In this drawing, this is supposed to represent a small tumor that's just in one lung. And as you go up to stage 2 and stage 3 and stage 4, the tumors get larger and they start to spread to lymph nodes that you can see here. And then stage 4 is when the cancer spreads to another part of the body. And one of the reasons why it's so very important to detect cancer at the earliest possible stage is because the chance of cure, unfortunately, goes down. These are numbers for lung cancer, but each different type of cancer, the chance of cure gets smaller and smaller the more advanced the stage gets. And so it's ideal to detect cancer in what we call a preclinical phase, where there's no symptoms. So you can imagine there's some time in a patient's body where just one cancer cell forms and then it divides and becomes 2 and 2 becomes 4. And there's a period of time where it's growing without any sort of symptom or problem to the patient. That's the preclinical phase. That's when we want to detect cancer early. When symptoms start, which for lung cancer might be a cough, and if a primary care doctor sends someone for a scan to evaluate a cough, then that's really not screening anymore. That's found because of symptoms. And it's definitely to our advantage to try and find cancers in that preclinical phase if we can, but it's not so simple because different cancers grow at different trajectories. And so here, this author has described 3 different types of cancer behavior. One is a turtle, one is a bear, and one is a grenade. And you can see by the angles that they're growing faster and faster. And this yellow dotted line represents the time at which the cancer starts to cause symptoms. So anything below the line is that preclinical phase. And the red line at the top, right here, depicts when the cancer gets so advanced that it might threaten someone's life. And so there are some cancers that grow very fast, and that they've depicted that here as a grenade. Those types of cancers can be harder to screen for because the window of opportunity between when the cancer even begins to when it causes symptoms to when it can cause life-threatening problems, those windows happen very, very quickly. There's also cancers that creep along very, very slow, what the artist here has called turtles, where it may be that the patient actually dies from natural causes before that cancer was even going to cause any symptoms. And those cancers we don't really want to screen for either because it may end up in patients being treated for a cancer that was not going to affect their natural lifespan. What we really want to do with cancer screening is find these cancers that they've termed as bears, where there's kind of a gradual increase with a reasonable period of time before the symptoms start that cancer can be detected, and also for which we have treatments that can cure cancer if it's found early. So not all cancers are ideal candidates for screening. Then some of the other issues that complicate this whole screening situation. So we talked about the natural pace of the cancer, the first bullet point. How well can we cure early stages of the cancer? Most of our early stage treatment revolves around surgery or some kind of surrogate for surgery, like maybe a focused radiation therapy. Medicines are increasingly helpful, but medicines such as chemotherapy and immune therapy have traditionally not been the focus of early stage cancers. It's usually more the surgeon's milieu. How sensitive and specific are our screening tests? So some screening tests have a lot of false positives. Some screening tests don't capture all the patients who do have cancer. And so we really want to find a screening test that works very well. But in addition, the population that we test is important as well. Because you can imagine, even if you had a great test, it's not right 100% of the time. So this table represents a thought experiment for a screening test that's very, very, very good, 100% sensitivity and 99.5 specificity. This test has very few false positives and false negatives. However, if you use it on a population of patients who almost none of them have the cancer, you're still going to end up with more false results than true results. And so, for example, here with some calculations that talk about the positive predictive value, or the chance that a positive screen equals a true cancer case, with the same test, that positive predictive value can change quite a bit depending on how prevalent the cancer is. So if you talk about a cancer that exists in 0.1% of those who you're screening, then the test is only 1.9% likely to represent a true case. All of the positives you get back, 99% of them are going to be false positives. So that's not a very good screening test and or screening population. But you can see that even just an increase to 4% prevalence makes that chance that the positive test represents cancer go all the way up to 89. And if you go to a 20% prevalence of the cancer, then you get up to 98% with your screening test. So all of these calculations are important. That's why there are guidelines for certain screening. So, for example, you may have heard in the news recently that colon cancer screening with colonoscopy used to be recommended for adults when they turn 50. And now they're recommending it at 45 because they see the prevalence of colon cancer going up in those age 45 to 50. So it wasn't until they saw that prevalence go up that they then made a change in the recommendations. So how do we put all these different complicated factors together? One simple number that a lot of researchers use to judge how good a screening test is something called a number needed to screen. So it takes into account how good the test is, how sensitive, how specific. It takes into account the population, how prevalent is the cancer of interest in that population. A lot of these factors that we were talking about. Also the natural history, the speed of the cancer if left undetected. And so we'll talk a little bit about that. This is really this magic number that different organizations and Medicare use to tell us whether they recommend screening. So screening, it's a pretty high bar to get to this, ideal number needed to screen. If we look at this graph, so the American Cancer Society puts out every year, same looking graphic, and so we can follow what the cancer killers are in our society, and they separate it by men and women. And I think many women are surprised to see that the number one cancer killer in women is actually lung cancer. 289,000 women die of cancer in the US every year, and 22%, basically 1 in 5 of those, dies from lung cancer. So lung cancer is really the number one cancer killer. Number 2 is breast. Number 3 is colon. Then you can see pancreas and ovary. And as far as tests that are recommended today, we have screening tests for some of these top killers, but not all. So we do have a screening test for lung cancer, which is a low-dose CT scan. It's only recommended currently in people that are a certain age and have had a certain smoking history because of that issue with prevalence. And so you do have to be a former smoker or current smoker to get access to lung cancer screening. That's something we're trying to change because actually Many people being diagnosed with lung cancer today have never smoked or smoked way back in college decades ago and quit, 40 plus years ago, and wouldn't qualify for this screening. So anyhow, there is a screening test for lung cancer. There's a screening test for breast cancer, the number 2 killer, of course, with mammography. There is a screening test for colon cancer with colonoscopy, but there's no screening test for pancreas cancer, none for ovarian cancer. In fact, the only other cancer that has recommended screening for women is cervical cancer with a pap smear. So what about this number needed to screen? How good are the handful of screening tests we have? These are the 4 screening tests for women: low-dose CT scan, colonoscopy, mammogram, and pap smear. And the number needed to screen, in other words, the number of women that you need to screen in order to save one life from this type of cancer is listed here. You can see that actually the lung cancer screening is by far the best. You only need to screen 300 women, smokers, to save a life. You had to do 1,000 colonoscopies to save a life from colon cancer, probably close to 2,000 mammograms to save a life from breast cancer, and even more than that for pap smears. In the next column, I have the percent of women who are eligible for these tests who get screened in the US. So I would say we're not doing great across the board. I'd love to see these numbers be 95+%. But we are screening between 60 and 70% of those eligible for cervical cancer, breast cancer, and colonoscopy. We are doing an atrocious job with lung cancer screening. Only about 5% of people who are eligible are having the test done. And there's a lot of complicated reasons for this, which is not necessarily the focus of what I'm going to talk about today, but a lot of it has to do with the way that lung screening programs have to be set up. So a lot of hospitals aren't able to get the program together. Luckily, Nantucket Cottage Hospital does have a lung screening program, and Massachusetts is actually the #1 state in the country as far as how many of our population have been screened for lung cancer. So that's something that I'm really proud of. And there's a lot of people across the state working on that. But even so, in Massachusetts, we're only screening about 40% of eligible adults. And in many states, they're screening no one, which is why the average is 5% across the US. So what are the major research needs in this area? What are we working on at my center at Mass General, which is the Center for Innovation in Early Cancer Detection, where we're bringing together lots of different specialists from the surgical fields, from medical oncology, from the different screening procedural fields like the gastroenterologists who do colonoscopies, the radiologists who do those mammograms and those lung screening CTs. And we're also bringing together engineers from MIT and people from industry who are developing novel tests. We are really trying to gain the ability to screen for additional types of cancer, especially pancreatic and ovarian, which are 2 very important cancer killers in women and have no screening test right now. And we're trying to improve existing tests and the testing structures. Like I was saying, we have a test for lung cancer, but only 5% of women are taking advantage of that test. So we have to change our structure of our healthcare system and maybe improve the tests to make them easier for people to take part in. So the 2 main areas where I think advances like this are going to happen over the next couple of years are in blood testing and artificial intelligence. So there are, when you go to medical meetings these days, there are often several hours worth of lectures about all the different new blood testing technologies that are out there. So I just want to give you a flavor today, but there are a lot of really cool things that are being developed. There are also some things that are out there that people are trying to, I think, push forward a little bit before it's ready. So one thing is that if you see an advertisement or if you get forwarded an email about something new for cancer, it's always good to talk to a trusted physician of yours about whether this test is something you should take part in, because there are some potential harms that could come from participating in tests that haven't been shown to help people. So let me give you a little bit of an introduction about these blood tests. So the whole idea with blood testing for cancer detection is that by extracting a tube of blood from someone's arm, you might be able to look at enough of the components in there to be able to tell that someone has cancer. This is a really tall ask for the tests that you're running, because a tube of blood is just a small amount of what's circulating around the whole body. And of course, what's circulating in the blood doesn't necessarily reflect a cancer, especially an early stage small cancer that might be hidden somewhere internally in the pancreas or in the breast or in the lung. A lot of the tests are looking for something called ctDNA, or circulating tumor DNA. And that's depicted in this drawing as these little colorful pieces of DNA that have burst out of cancer cells and have leaked into the blood. However, all of the healthy cells in our body also sometimes leak DNA as they turn over as part of just normal maintenance inside of our body. So you've got healthy cell DNA, and you've got tumor cell DNA, and it's mixing together and it's traveling throughout the whole body. And these technologies have to try and pick out a signal, which is kind of like finding a needle in a haystack. There are a lot of different techniques that are being tried to see how we can identify such a small signal in such a sea of noise. And it turns out that the DNA that comes from tumor cells actually has some identifying marks on it. And so we can take advantage of those marks and look at things called the methylation parameter, or the fragment size of the DNA, and try and understand, is this coming from cancer? But the second big hurdle, when even if you find something that you feel like represents tumor DNA, is then telling the patient, where did this come from? Did it come from your lung? Did it come from your colon, your breast? Where in the body is this potential cancer? And so I think that's really, there are different philosophies about testing with blood tests for ctDNA. And some of the companies that are out there are really looking for a one-size-fits-all test that, anyone over the age of 50 could get a blood test, and it would tell them not only you might have cancer, but it looks like it might be coming from the GI tract somewhere, or it looks like it could be either breast or lung, something like that. Then there's another strategy, which is to take a high-risk population. So having a population where the prevalence of that cancer is a little higher makes the test a little bit easier in terms of the bar that it has to cross. And so, for example, maybe you're going to look at smokers and test them because they might be at risk for certain cancers that are linked to smoking. Or you might test women who've been on hormonal therapy. Or you might test people that have diabetes. Or, you try and find a risk factor for a certain disease and test those patients. So there's a lot of different competing ideas out there about the best way to do it. But I want you to keep your eye on this space, because I think there's some really exciting things coming. And then the last thing that's also coming is artificial intelligence. A lot of this has to do with radiology interpretation. And the important thing is that it's not just a better radiologist, but I think the magic of artificial intelligence for cancer detection is that it may help us predict the future. These are 2 different lung nodules in 2 different patients of mine. Right here is one, and right here in a different patient is another nodule. They both looked worrisome to the human radiologist and to me, who was looking at them, that they might be cancers. Both patients went to surgery because it looked like they were early stage, small tumors that could be resected. And it turns out one of them was a cancer, and the other one was not. It was just inflammation. It was a scar tissue left over from a pneumonia maybe that the patient had 10 years ago. We don't know. But there are people who are trying to figure out if a computer-aided radiology could tell the difference between those. But also, there's so much other information in a CAT scan besides just this little area or just this little area. we see the heart, we see the lungs, we see the bones, we see how much soft tissue there is for different patients. There's so much information there, and when a computer looks at that and looks over thousands of patients for patterns, the computers can detect patterns that our human brain would never recognize. These are the types of algorithms that when you log into Amazon will say, hey, are you considering buying a blender? And you're thinking, that is so weird because I was logging on to look for blenders. How did they know that? Like, this is the type of algorithm that can potentially help us tell who's at risk for cancer based on patterns that are being seen. So one of the things we're doing at our early detection center is working with some of the computer scientists at MIT and trying to use screening studies that might be done in 2021 to not only screen for cancer that is present in 2021, but to also say, is this person at risk for developing cancer in 2025 or 2027? Should they be watched more carefully, or should they go on some kind of preventive treatment because it looks like they're at really high risk based on this algorithm? So I think there's a lot of really exciting things being done. I'd be happy to talk with you more during the question and answer session or during the reception about some of these. I had said, let's take questions, but the question time is not now. And this is a picture that I just took today at the beach at Quidnet. So thank you so much for having me. Are we going to go right into the next speaker then? Okay, Ugna, you guys are up.
Talk more.
Hello, thank you so much for having us here. And as many of you know, the cancer program at Nantucket Cottage Hospital is our work of love. And Gretchen and I speak many times a day on the phone and passing and taking care of our patients. And when we were asked to speak for this gathering, we were asked to share a little bit about perhaps a patient story and what are the services we offer and how we take care of our patients. And we felt that a best way to depict that would be to let you be a fly on our wall when Gretchen and I are speaking to each other on the phone. Okay? So, hey, Gretchen, I just got a call from Beverly Moy at the Mass General Cancer Center about a new patient, 36-year-old, with breast cancer being referred to us for treatment.
Oh, got it. So awful. What kind of treatment is she facing? How can we help?
She's gonna go with DDAC, transitioning to her septum perjeta. So she's gonna be with us for a long time. She's gonna be with us with a little bit over a year. So we'll get to know her really well.
Okay, so safety considerations first. Let's start with the chemo risk factors. So the drugs are adriamycin and Cytoxan. Are we experienced in this? Yes, very. Is there a chance a patient could have an adverse drug reaction? Always. Many chemo and immunotherapy run that risk, but our infusion staff is 100% certified in oncology and biotherapy administration. They're trained to anticipate and react swiftly to this. We also know both these drugs are given intravenously, and adriamycin in particular is a known vesicant. That means it can cause extensive tissue damage if it leaks from a vein. It's a very serious potential side effect we don't ever want to experience. The risk is much higher for infusions in arm veins, so we're going to have to recommend that your patient, our patient, get an implanted port in the chest for safety.
I've already spoken with Dr. O'Connor, and he will meet with the patient and I'll arrange for a port placement. Remember when we used to have to send patients off island for ports?
Oh, very well.
That wasn't even that long ago.
It wasn't that long ago. Oh, all right, that's good. Get right on top of that. All right, so you say the patient is 36 years old. Wondering, considering her age, if she has children, and is she planning on having more? We'll have to inform her of the risks.
Well, she does actually have a 6-year-old, and she did meet with Mary Sabatini at Mass General Cancer Center for fertility planning and fertility preservation. So all of that workup is underway, and she's gonna undergo egg harvesting. So we'll get her after that is completed.
Okay, those are always difficult conversations. Way to get that done out front. She'll need that information to make care decisions. It's very important to get that started before we give chemo. Now, do you think this patient would be interested in cold capping to deter hair loss from the chemotherapy?
I am sure she would. She's a working professional, and hair loss makes it really hard to maintain your privacy. And how about dignity and body image? Oh, I'm sure she would be interested. And you do know that children experience just even increased trauma from patients undergoing treatment when they observe that through the hair loss.
I know this very well, absolutely. With that regimen, there's a pretty good chance now she can retain hair with scalp cooling. We'll show her the equipment, we'll explain how scalp cooling decreases circulation to the hair follicles and decreases the amount of chemo that reaches it and usually causes the hair loss. I just hope she can afford it.
I know, $2,000 is a lot of money, and insurance does not cover that.
Let me put her on the nursing cold cap teaching schedule. We'll see if she can come in to try the cap. We'll answer any questions. She can learn about the process and perhaps qualify for some funding. What's her name?
Her name is Mary Strauss.
Oh, wow. Oh, no. So I've been working with cancer patients for 18 years now, and one of my first patients was her mother. She also had breast cancer. We've been offering chemo services at the hospital since the mid-90s, and cancer services in general have improved greatly since then, and our local practice is a lot more robust. We went from treating a handful of patients, seeing an oncologist from the Cape about monthly, to a partnership with Mass General Cancer Network. There's been great advances in treatment options like the development of immunotherapy, genetic testing, and many more options now for symptom management. Back then, we would actually have patients vomit during treatment. That wasn't that uncommon. And 100% of patients who were treated with this sort of chemo for breast cancer lost their hair, 100%. Our new patient would be really worried if she's heard stories about treatments from her mother, which she most certainly has.
Oh, things are so different now. Our cancer center is so different, and also the treatments are so different as well. And thank you so much for that, Gretchen. I'll make sure to, when I meet with her for a chemo teach this week, I'll go over a great detail about how we're going to manage her symptoms and prevent them, because vomiting is not normal part of chemotherapy anymore.
No, we hardly see that anymore. So, considering the family tendency for breast cancer, has anybody talked to her about genetics counseling?
Well, luckily, Mass General Genetics team will send the lab kits to our lab here at Nantucket Cottage Hospital, and we'll set up a virtual consult for her to review those findings.
Awesome to have that available. And wondering, does she have any other supportive care service needs?
I'm sure she does, and we're getting to be quite robust, which is so exciting. I'm a big fan of early palliative care referral. And we know from research that patients do so much better when palliative care is involved early on. And we have a great program for palliative care, support groups, even yoga for cancer patients, individual counseling. And we're starting to get nutritional services and social services involved. But in the beginning, there's a lot happening. There are a lot of appointments, a lot of demands on patients' time and schedule. She's going to need to be here probably in the beginning 3 times a week. She's going to need labs. She's going to need visits. She's going to need treatment planning. She's going to need chemo teach. So I tend to introduce the supportive services slightly in the beginning, and our nurses do such a stellar job keeping an eye on our patients that we can gently continue with the referrals as we get to know the patient better.
Sounds good. It certainly is a very overwhelming time. And the nurses will continue to reassess her every time they come in and make suggestions and reminders about what services are available. When do you think she'll be ready to start treatment?
I'm hoping to get her scheduled for imaging here locally, get a CAT scans and echocardiogram done. Sometimes those can be tough, but our team has been so great getting our patients squeezed in. So I'm really hopeful that as soon as that's done, we can get her started on treatment.
Okay, I'll reach out and see if we can make an appointment that works with her job and her childcare situation.
I know the nurses always are so conscientious of making sure that our patients would be finished with their chemo on time to go pick up their children from the camp.
We certainly try. Okay, Ugna, I think that I have everything I need to know. We'll review her chart.
Oh, Gretchen, you have to see the socks that Lisa got for Mrs. Smith for her last day of chemo. You know how she loves cats, so she got her a pair of socks with these cutest little kittens on them. You're gonna love it.
It's true. Yeah, I did. I'm so happy for Mrs. Smith, and I love how the nurses really go out of their way to take care of the patients.
Yeah, they do.
Oh, Ugna, there's a card on your desk for Ruby's family.
Oh, yes. Thank you so much. I'll sign the card. What a wonderful lady. We're gonna miss her so much.
We are. Talk to you in a bit.
So
Thank you. Thanks so much. We just wanted to sort of give you a little taste of what we do all day long. And really, those referrals come way too often. And I wanted to elaborate a little bit. You know, obviously, we enhanced that conversation. Ugna knows everything about scalp cooling. But just to emphasize that those services we were just discussing, that those are all take place here. Of course, the patients do have to go off island for certain things, but everything we were talking about, we do locally. All that chemo, that placing an implanted port, the scalp cooling, all the supportive care from PASCON, and nutritional services. There's so much we're doing local now. I'm just really proud to be a part of the program and wanted to elaborate a little bit on scalp cooling because it's a relatively new service we're offering. We've been at it just about a year and a half. And as Ugna said, it's really important. It's really important to patients in terms of maintaining dignity and body image. Because when those things are compromised, the treatments don't go as well. People who feel well do better. Evidence shows that. And also it is about privacy. Some people just, they don't want it out there that they're going through this. Most patients emphasize how they just want to do normal things, how normal things feel best. And that is working, taking care of kids, going to book club. And whatever we can do to make patients feel normal, we try to do. We really want to do that. Anybody who's spent time in Nantucket knows how hard it is to keep business to oneself. And I saw your car at the hospital and what were you doing on the boat. So we're really thrilled to offer this. I don't kid when I say that 18 years ago, people lost their hair, people were throwing up, and cancer care is different now. And it's going to keep getting better. So thank you.
Such an honor to be here in front of this group of women. I was thinking about the first time I got into mind-body medicine about 19 years ago, and it was because two people I cared about so much went through cancer. And it was because of people like you that they're alive today. So just so honored to be here with you all. So how many of you here are feeling a little bit stressed? Yeah. Maybe just today or in the last week. Maybe you need a Beastie Girls song to start off. What I thought I would do to start off the presentation is I'd like you to turn to the person next to you. And I'd like you, at the same time you're turning to that person next to you, squeeze your fists as tight as you can and tell that person that you are having one amazing day. So why is that so silly? Because normally, when we're squeezing our fists, if you're in a bunch of Boston traffic or Nantucket traffic here, you're not really saying that things are great. And usually when you're squeezing your fists, you're usually holding your breath. And you're usually holding your breath in your upper chest thoracic area. So one of the techniques I'd like to show you today, if any of you are feeling a little bit stressed, is to just take a moment and bring your chest to your thighs. So whenever you're having a panic attack, what that will do is it'll help you to get into the belly breathing, that diaphragmatic breathing, and you can naturally take a few easy deep breaths that way. So it's a nice way to just kind of start off. So let me just ask you guys, what is actually creating stress in your life right now? What would you all say? Work, the pandemic. It's kind of this constant stress. You know, years ago, as we evolved from cavemen and cave women, we went in the stress response on average 50 times a day. But now it's a constant stress. We wake up, our blood pressure rises, our oxygen consumption rises, our metabolism rises, and then we have another stressor. And a lot of us have felt like throughout this pandemic that we haven't had a chance to actually just calm down and to relax. I do want to talk to you about a couple of research studies. As you guys know, the field of mind-body medicine, I work for Herbert Benson, and back in the late 1960s, early 1970s, he actually research validated this approach. And what he found is that when people practice a repetition, that it brought them into the present moment. So let me ask you for a moment, how many of you, when you're watching your thoughts, do you think your thoughts are in the future? And how many of you think your thoughts are in the past? And how many of you think your thoughts are in the present? So turn to the person next to you. What percentage of your thoughts are in the future? What percentage are in the past? And what percentage are in the present moment? Let's take a minute just to chat with the person next to you. Here we go. So 50% of our thoughts are about the future, what's going to happen. 40% of our thoughts are in the past. Oh, I should have done that. Oh boy. And only 10% of our thoughts are in the present moment. So if that's true, we're here, our bodies are physically here, but our minds are always somewhere else. So it's something to kind of think about. And all these practices teach us to be in the present moment, but obviously that's not easy. So as I was saying before, there's quite a bit of research now in this field. Two places, as you know, that are good to go for any research if you're interested. One is PubMed, like going to a pub, MED, and the other one is Google Scholars. There's several studies now that are quoting this relaxation response. So as they said in the intro, I work for the Benson Henry Institute. If any of you have heard of Herbert Benson, he wrote The Relaxation Response. It might be a book that you might want to pick up. But as you go through PubMed, you will see the relaxation response has been cited in many periodicals and research as well. So here's something just to kind of start to think about. One is about gene expression, and the other one is about the brain. So usually I thought that, when I came to the world, these were the genes that I had from my parents. But actually what we're showing is that meditation actually alters gene expression. And these are the genes that control antioxidants and aging. And what's particularly interesting about this study is that this is the first evidence that meditation elicits specific gene expressions, and not only long-term meditators. When I started in the field over 20 years ago, I thought, oh gosh, I need to be like the Buddha, actually make changes in the body. But this study was only after 8 weeks. And this study was by our past medical director, if anyone wants to look it up, Jeff Dusek, D-U-S-E-K. And the next one that's interesting I thought to bring here today was about the brain. What I think is very cool about this particular study is, as you know, as we age, this cortical layer can become thinner. But in this part of the brain, when people are meditating regularly, that we see in the fMRIs and the functional MRIs that this part of the brain is actually thicker. So I know I just have a short amount of time. I wanted to quickly talk to you about research, although I love kumbaya and smelly candles. I wanted to make sure you all knew it's very research-based, what we do at Mass General, a little bit of stress physiology, and then I want to leave today to give you a couple of quick tips for you all. Trouble with these, David, you don't know what the word relax means. So, How many of you, when you come on vacation here, are you able to just go into relaxation mode? Or does it take you like a few weeks or even to really kind of get there to allow our bodies to really calm down? Some of us don't even realize the tight tension that we have over a period of time. How many of you have found, just through Zoom that you have more headaches and tension and eye tension? Yeah, so that's really common as well. So we have a huge focus, on pharmaceuticals and surgery, but a very little focus under self-care. So let's turn to the person next to you. What do you think the 4 things under self-care that you can do to balance yourself? Of course, I believe in pharmaceuticals. Thank goodness we have them, and chemo and radiation, all these things that we really need to have in traditional medicine. But what are the 4 things under self-care that we can do to really pump our bodies and to be as resilient as possible? All right. So 1, of course, is nutrition, right? Second is exercise. Third is any kind of relaxation, stress reduction practices, meditation. And the 4th is sleep. I want to spend just a couple minutes on sleep. The reason why is so many of the people that I work with individually right now have had a hard time sleeping over COVID for many different reasons during this pandemic. How many hours do you think we should get from sleep a night as adults? 7 to 9 hours, yeah. And what's tricky there, the National Sleep Foundation, they write a dash. So you don't know, does that mean 7? Does that mean 8? Does it mean 9? So you really need to ask yourself, how much sleep do I need? But an interesting study on PubMed that you might want to look up is, the N was only 23, but it was about cherry juice, not the cherry juice that has a ton of sugar in it, but the real tart tasting cherry juice, that 2 ounces of that actually is working similar to melatonin. So thinking for yourself, what are things that we can do naturally other than pharmaceutical drugs to help us to sleep? The other thing I want to mention that seems to help people is yoga nidra. So there are 85 sleep disorders out there, as you know, but the number one reason why we have a hard time sleeping is because our mind is busy, which was what was why I brought that up before, is our mind is always racing. Sometimes we call it the monkey mind. We have one thought going from one branch to another branch to another branch. And so what can we do to kind of bring that mind to the present moment to help us to go to bed at night? Yoga nidra, one that I like is Jennifer REIS. It's a YouTube video. But I think the reason why it works so well is there was some research back in 2007 by Tang. And this guy Tang talks about how multiple techniques reduce people's anxiety. So yoga nidra starts out with an intentional phrase, then a body scan, and then imagery. And I think by the end, it really helps them to sleep. The other quick technique that I'd like to show you today, if you're having a hard time sleeping or some anxiety, is the just this breathing. So I welcome you to get comfortable as you can in your chair. You could dig your feet in the ground, because we know when we're panicking or we're nervous, we tend to be out of our bodies. So digging our feet into the ground gets us to here and now. So I welcome you to take an inhale. And on the exhale, saying to yourself, just. And one more time on the inhale. And now count from 10 to 0. 10. And now another inhale, exhale, 9. Inhale, 8. And all the way down to 1. And now inhaling the word this, and then counting from 10 to 1, slowly to yourself. Inhale, and on the exhale, 10. And now inhaling just and exhaling this a few times. And when you're ready, beginning to gently move your fingers or your toes. And slowly beginning to open up your eyes if your eyes were closed. So really simple. You know, I think that people feel like we don't have enough time, we're all so busy, but you really can shift your physiology. I don't know if anybody felt a change, or maybe their heart rate was lowered or a little bit calmer. If you find that that's really challenging, and for some of you it may be, even just to kind of sit for a minute can be really hard, you can also just try dumping out your mind each day, giving yourself 10 minutes, and kind of doing a brain dump out. So, you know, if I said to you, don't hit the ball in the water when we're playing golf, don't hit the ball in the water, don't hit the ball, eventually you hit the ball in the water, right? Or if someone says, don't worry about it, don't worry about it, you're like, I'm already worried about it. So if you do the opposite and you're gentle with your mind, it becomes easier and easier to create a quiet mind and to let go and to decrease your anxiety and to help you to sleep. Great. So I know I just have a couple more minutes, the timekeeper here. Okay, so I wanted to end with two things. One, I'd like to end with some interesting research from Barbara Fredrickson. So after this very unfortunate time, after 9/11, what group do you think, my favorite researcher is Barbara Fredrickson in the field of positive psychology, and she found that one group who witnessed 9/11 was much more resilient than the other groups. Let's turn to the person next to you. What do you think that one group, why was that one group much more resilient than the other groups of people who had witnessed 9/11, who was right there? What would you say? What did they have? What quality did they have? What was the quality that the one group had? It was appreciation. They were able to say, even in that terrible time of our nation, that there were people who volunteered, there were social workers, there were doctors and nurses like all of you who came out to really bring our country together. So appreciation is huge. So I thought I would just end with, if you guys want to turn to the person next to you and say something that you appreciate. And as you're saying it, you know, a lot of times we do things like a to-do list, like I appreciate family, I appreciate this person, but actually really experience it and tell the person next to you what it is about you appreciate. The other thing, there's also interesting research from Emmons and McCullough who talk about keeping gratitude journals. And so what I find kind of neat about looking at studies is, you know, gratitude or saying these types of blessings before eating are part of a lot of our cultures or some of our traditions. And now we see, wow, if we do gratitude, we actually sleep better. We report fewer physical symptoms. We make more progress towards our goals. Now there's a study associated with it. But let's just take a moment and turn to the person next to you and share with them something that you fully appreciate as we bring our lecture here to a close. Great. Great. Excellent. Thank you all. And I just thought, you know, I love research, so not to be too much of a nerd here, but this is the research of Emmons and Cullough of gratitude. So such an important thing to keep this gratitude on a daily basis. Even in these really hard times, there's always even the smallest things each day that we can have gratitude for. Great. Yeah, thank you all.
Rayna, thank you very much. Speaking of gratitude, I'm very grateful for everyone who's here in person and for all of our Zoomers. I'm Mary Tafe, and fun fact about me, I have 2 Nantucket natives, and one of them is in the audience today. She was helping out seat everyone, and that's Abby. Shout out to Abby. So at this point, we'd like to open up the floor for questions. For both people here in the audience, I'd like to start with people here and then move on to some of our Zoomers. And for the Zoomers, please use the question and answer button, not the chat. Okay, so the question and answer for the Zoomers. Is there anyone here who has a question for any of our panelists? Oh, great, wonderful. Oh, excuse me, but for the people asking questions, can you please identify yourself and speak loudly in the microphone?
Christine Colby Gerardo from Washington, D.C. For the learned doctor on the right, which between pancreatic and ovarian, where do you think a breakthrough could come first?
Do you want us to use the microphone too? Oh, yes, of course. Sorry, apologize. There you go.
Yes. So
I'm not sure where the breakthrough will come first. Sometimes it's hard to predict. I think that pancreas cancer is a more vascular cancer, and so some of the circulating markers might be a better fit for pancreas cancer. Ovarian cancer can be really difficult because it's kind of encompassed inside the lining around the abdomen, and it doesn't always have as many circulating markers. However, I think there are a lot of novel techniques that researchers are looking at for ovarian cancer that might involve some of these artificial intelligence, looking for patterns, looking for subtle changes in the person's health parameters over time, and maybe not the normal things, that we're so used to looking at in medicine. We look at the blood pressure, we look at the weight, we look at a certain small set of labs. And I think some of the beauty of this artificial intelligence is it can really go way beyond that. Some countries have health systems where all of the data basically from birth till death is all in one electronic form for the entire country. So Denmark is a country like that. And my research collaborators at MIT have been looking at some of those lifelong records and mining them for patterns. And they've been able to really predict who's going to come up with a few different types of cancers because they see these subtle changes in our health over time that would not be picked up by a human physician. So I think there's a lot of really interesting techniques out there, but I'm not sure which one will get to the finish line first.
Thank you. Woman in white, please.
I'm Cynthia Danforth from Boston and Nantucket. And thank you all for being here. You are all very inspiring, I have to say. I do have a question about screening. And, coming out of the pandemic and thinking about home screening, for example, a mini COVID test or where we're going with that, I'm not sure. But Cologuard sort of, creeps into my mind as a technology that allows us to at least begin the screening process doing something at home that might then take you further, to a colonoscopy. And I'm just wondering, just generally, do you think there's a movement to empower people to do sort of that home screening some way before, or, in a pre-screening, I guess, fashion before you take it to the next step?
Yeah, no, that's a great question. And many of you have probably seen the commercials on TV for Cologuard, which is an alternative to colonoscopy, where you would take a sample of stool at home and send it in. And the analysis they do is actually very similar to what I was describing about the circulating tumor DNA in the blood. They actually look for tumor DNA fragments that might be in the stool as a way to suggest that there might be a cancer along that track somewhere. So I do think that there's a lot of consumer demand for things that can be done easily, things that can be done at home. If the Cologuard test is positive, you then have to have a colonoscopy. But, for people who it's negative, then they may have saved themselves a colonoscopy. And that's the FDA indication for that one. What I really like about the Cologuard test is that they went through the full process with the FDA to get a label that proves that, that basically states there's research proving this is helpful to patients. A lot of tests out there can be marketed without that FDA certification. And those are the ones that I worry a little bit that they're not quite ready for prime time, but people can access them. Cologuard is one that went all the way through the FDA, and I think that's the right way to go. Lead with the science.
Thank you. Manu.
Hi, Manu Palanjan from Boston and Nantucket. I have a question. Thank you all. This was fabulous and so informative. Could you explain to me, please, or all of us, you mentioned cold cap treatment. I'm still in the dark ages and I have no idea what you're talking about. If you could possibly give us a little more information in that and how we can help and or get to support those that need it.
I'll take that one.
Thank you.
Is this working? The cap. So it's not totally new technology, but it's newly widely available. It's pretty simple, really. There's a gel cap that attaches to like a refrigerator with a cooling system, and it runs coolant through the cap. And by cooling the scalp, we actually cool it down to about 32 degrees. This prevents the chemo from getting to the hair follicles. So chemo works by targeting rapidly dividing cells, which are tumor cells, yes, but then accidentally gets the hair. It gets the gastrointestinal tract and the bone marrow as well. And so to save the hair, we cool the hair follicles, and that decreases circulation and lets less chemo get to the hair follicles, which helps retain the hair. Yes, so we run the cap during the chemo treatment. Before, during, and after. And the exact period of time for cooling varies depending on the chemotherapy, the type of hair the patient has, but it averages about 2 to 3.5 hours. Is that good? A good question. Side effects are to be cold, makes you cold, and chills, and sometimes headache. So we offer warm blankets, and usually it's like getting into a cold pool, like, oh, it's awful, and then, oh, not too bad. It's okay, I'm going to take a nap. And most patients, everyone I've seen has tolerated it well enough to not stop it because of discomfort, and we haven't seen any ill side effects. Oh yeah. So that's a good point. One thing I could mention is that people are so fearful of losing their hair that about 8% of patients will decline their first recommended treatment if it involves total hair loss. We'll decline it completely, or the portion that causes the hair loss. So it's really important for survival to offer this service.
Thank you.
Oh yeah, it's for men and women. We just use the female breast cancer patient as an example, but there's a number of drugs that cause total hair loss, and either men or women can take advantage if they're on those drugs.
Hi, I'm Jenny McDowell. I'm from Boston and Nantucket in the summer. Would you talk a little bit more about genetic testing and how important it is if you have cancer in your family? Thank you.
So there's 2 types of genetic testing. One is to look at genes that could run in the family. And you're right, if you have a history of cancer in the family, that would be something that you could talk to a genetic counselor about. These are specially trained geneticists that will take a very extensive history about your family and the different conditions, and then make a recommendation about what type of genetic testing might be suitable for you. There are many different genes that can be passed down from one generation to another that are associated with a higher risk of cancer. There are also a lot of families that clearly have a tendency to cancer, but we don't know what the gene is. And so genetic counselors are really important because they can go through all of that with each patient and individualize the recommendations and explain, what we know and, importantly, what we don't know. But another type of genetic testing that's very important for cancer treatment these days is testing the tumor itself, not looking for genes that could have come from the patient's parents, but actually looking for genes that are causing the cancer to grow. And most solid tumors should be tested. It's especially important in lung cancer and a couple of other cancers where there are a whole variety of targeted treatments available. But more and more, every type of cancer should undergo a broad genetic screen to look for potential effective therapies. And patients get confused because they wonder if the testing that we're recommending puts their children at any, are there implications for their children? So there are two different types of genetic testing, those looking at the genes that you were born with and could pass on, and those looking at just the genes in the cancer that you weren't born with.
Oh, pardon me.
Go ahead.
I'm Judy Rosenberg from New Jersey and Nantucket. So you talked a lot about anxiety for people with cancer, and I do go for my annual mammogram and I've gone for my colonoscopy, but I have such anxiety going for that mammogram. It's literally like a countdown till it arrives, waiting through the tests, and then the countdown starts again. How would you suggest, because I think that I'm sure a lot of people do not get tested because they're so fearful of the outcome.
Did you asking me? I have the same kind of anxiety, so I understand. It's interesting because I teach stress reduction and anxiety. So my mother had breast cancer, so it is something that's scary for me, getting mammograms. So I usually I have a couple friends who feel the same way, and we actually support each other and go with each other to mammograms. But I go to a place that is so mind-body-ish. It's not a typical, it's beautiful, it's very peaceful. I usually meditate in the waiting room with a friend beforehand to get myself into a very quiet and relaxed state, which is really helpful in doing positive affirmations. But I think that part of resiliency is social support. There's quite a bit of research on social support and resiliency. So if you have a group of women with you or a friend, I also think going to a place that you're really comfortable with and that you're really comfortable with the doctor. And I think meditating beforehand. Anytime you're going to take some time to lower your cortisol levels, your body will be less tense, during the mammogram and treatment. So.
Thank you. Do we have another question? Melanie.
Melanie Sablehouse from Nantucket, Naples. Dr. Sequest, I'd like to ask you a question about the upsurge in COVID and the Delta variant and your thoughts on that. What are we looking for in the future? And also we talked about vaccinations.
Yeah, it's on everybody's mind, and I'm not an infectious disease specialist. I'm an oncologist, but I think all of us in the medical field have learned a lot about COVID this year and about how to prevent the spread. And all of you here are wearing masks and are social distancing and doing these very important things. I think the news has been scary these last couple weeks, just reading about all of the uptick in infections and the hospitals in different regions that are getting full again and turning away patients from the emergency room. And I think we all have a lot of PTSD probably from last year about these things. I think that one of the reasons we were just talking beforehand about how there could be a new variant, and a lot of the scientists that study this are telling us because the infection has stuck around and keeps getting passed between different groups of people, it gives it a chance to mutate. And so one of the things that we can do to prevent future variants that might be even more infectious is to really stop this virus from circulating in our population. And so things that we're all doing today, like wearing a mask and social distancing and hand washing, I think are really important. And vaccinations are also really important because it prevents us from getting the, even if we do get COVID, it is extremely effective at keeping people out of the hospital and keeping people alive, even if they contract COVID. So it's much less severe if you get the disease if you've been vaccinated. So do you guys have any additional points you would like to make about COVID from your experiences? No, we're not through this. I think that so many people have kind of spiked the football in the end zone and are doing a happy dance and going back to their usual, but I think it's a little bit too early, unfortunately. We're not out of the woods yet. Question from the audience about boosters. I think there is more and more research coming out in the medical literature that a booster might be effective, especially if it's been a long time since you were vaccinated. If you were one of the first people that went in when the vaccine came out, now it's been more than 6 months, your immunity potentially could be waning. There's also a lot of articles coming out that talk about different groups of people, older people, people with immune suppression or on certain medications that maybe didn't get as much of an antibody response. But what we don't really know yet is how effective a booster shot is and how do we choose who to give it to and when. And also, we're kind of in a global situation where much of the world hasn't even received one dose of the vaccine. Many people in this country have not received one dose of the vaccine. And so there's a lot of debate and policy, really tough issues about this limited resource, who to direct it to, and how to get us out of this mess. So right now, as far as I'm aware, there's no recommendation from the CDC or from the FDA to get a booster, but it's a really important question.
Meryl.
Just to go along with that, after 6 months, let's just say you're at almost 6 months or past 6 months, do you think that it would be helpful to get an antibody test to see if?
So if you didn't hear the question, that was Meryl Breilauer asking, is it helpful to check your immunity, to get an antibody test and to see where you're at? I think it's a great question. There's also a lot of research being done in this area. But I think the sticky situation is that we don't really know what to do with that number. If it comes back saying your antibody level is, 150, what does that mean? We can't tell you yet. This means you have X% chance of such and such happening. We just don't know. So I think we're in a gray area where there's a lot of really good questions and there's not enough answers yet.
Great question. I do not see any questions from our Zoom audience. I think we have time to take 1 or 2 questions from this audience.
Thank you. Hi, I'm Laura Peterson from East Falmouth on Cape Cod. I just want to thank you all for this panel. And Rayna, could you confirm for us? So I've heard, because I know we're all very motivated women and we want to do meditating perfectly, I've heard that as you get pulled away, and then it's noticing that and bringing your mind back, that's actually where you're building the neural pathways. So if you get pulled away, that's a good thing, because that's where you're doing the work. I just want you to tell me I'm doing it right.
Well, it's not so much about doing it right or wrong. It's just doing it. It's like that old Nike ad. But our research is based on 20 minutes a day, and so it's really when the mind gets busy, which we all have busy minds. I even think the Dalai Lama, I remember him saying in one of his lectures that he has a busy mind at times. So we're all just human, but it's about when the busy mind takes you elsewhere, just gently bring it back to the present moment. But when I actually do some testing on my own body with heart rate variability, and skin conductance, I'm eliciting the relaxation response still, even if I had moments of a busy mind. So I think sometimes when we're going through times in our life of anxiety, we tend not to want to meditate, but it really is a practice. We say you want to meditate or medicate, but it really is important to do it in times when you actually have that nervousness, and even in times when you don't have nervousness. So it just becomes a regular thing that you do on a daily basis that you can access. So for example, if I was weightlifting every day with you and somebody was to move these tables here, you would bend your knees, you protect your lower back, because every morning we weightlift. So we're hoping that people develop this practice regardless of what's kind of going on in your external world. But each time that mind gets busy, just gently bringing it back to the present moment is, and just with ease. So, great.
Thank you. Do we have one more question? It's a good question.
It's a great question. There are so many people providing opinions. I mean, I'm one of them. I gave you my opinions today, but I don't study infectious diseases. I'm not a virologist. I think I think for one thing, the situation has changed. So I don't know the specific example you're talking about, but in general, there have been times in this last couple of years where it looked like the data was going in one direction and then things changed. And so the situation is changing. And I think people have, like with any topic, a range of opinions. I think for me, I do the holy grail that I tend to go to when I really need to know the answer about something like, should I go on vacation with my family or things like that. The CDC, I think, has probably the most comprehensive set of reviewed guidelines, but even that has changed over time. I think everyone's just doing their best and trying their best. It's a challenge, and I wish I had an easy answer.
Yes. Okay, so the question is, what is the approximate cost of the cold cap? And if I'm not mistaken, is it about $2,000? $2,200 per cap. And
For one person during their course of the treatment. The caps are so the patients purchase the cap, and the cap is a single-use cap, and then portion of that goes to the company.
so the question was, are the caps reusable? They're able to be used for one session only. Is that correct?
For one patient.
One treatment, one treatment. I mean, one
series.
treatment only. I apologize. One treatment only.
The patient uses it every 2 weeks, but they can't go to another patient.
One more question. Brenda.
Hi, I'm Brenda Johnson from Nantucket. My question, Gretchen, is how many cold cap machines do we have? How many patients can you treat? And I know that we have individual rooms for the chemo and infusion area, so if they can treat more than one, how does that work? And could you use another machine?
We have 2 machines, and both machines could serve 2 patients, but in most infusion centers, they're open and patients can sit adjacent, but our infusion center was built for privacy, and so the patients are treated in individual bays. So even though the machines are double machines, it's unlikely we'd be able to use them as double machines with our setup. So we have 2 machines, which means we can treat 2 patients at once. And considering that our treatment growth has seen 3 to 5% increase in visits each year in the last 5 years, I imagine we would need a 3rd machine probably in the next couple of years.
Do we have any other questions? Question?
Good question. Do you want to field? We won't. We don't have plans for radiation in Nantucket anytime in the near future. The specifics of building a center like that are massive, and we don't have the volume at present to consider such an endeavor. So we do work closely with Mass General and Cape Cod Hospital to make sure that the patients can have whichever is the most convenient way for them to get radiation. So for some people, spending 6 weeks entirely in Boston, so often the radiation is combined with chemotherapy at the same time. So sometimes it's easier if the patients can do it to go to Boston and get both at the same time. Other patients very successfully go back and forth to the Cape daily. It's often 5 days a week for 6 days, and they'll get their radiation every day. The radiation center is incredibly accommodating, giving them the most appropriate appointment for the transportation. What time is the boat or plane? And then we, on our end, accommodate the treatment side, the chemo side, for when they will get back. So we do the very best we can without a radiation center on the island. And the other question was cancer rates. Can you answer that? I'll hand off to Ugna on this one. It's complicated.
The short answer is that we don't know. I always speculate on the fact that because we're such a tight-knit community, I'm always curious, does it feel like everybody's neighbor has a cancer? Because we know who is undergoing treatment. We're just, it's so much more awareness. So I'm wondering about that. The other piece that we're hopeful for is as we transition to electronic medical records, and our electronic medical record system is a lot more fluid now. My wish, dream, and desire is that we're starting to analyze those numbers a little bit closer, and now we have better numbers to follow. So I'm hoping we'll be able to answer that question soonish.
All right. I think that takes care of it. I would like to thank our panelists who will be available for discussions later. Is that correct? But before we end, we have the honor. I'm honored to introduce co-founder of the event, Melanie Sablehouse. Melanie, can you come up and give us a word?
Thank you very much. These leading ladies that are sitting up here on this panel and so significant in their knowledge of your respective fields. We want to thank you because they are empowering us to be able to make the right decisions because, ladies, you are the chief medical officers. You're the CMOs of your family. And yes, 80% of all healthcare decisions are made by all of you. Gentlemen, do you hear that? We have some gender balancing here, which is wonderful in our audience, but you make them for yourselves, you make them for your kids. You'll end up, when you become my age, you'll make them for your parents. So this is significant. And that's quite frankly why we started Women in Wellness 5 years ago. And we wanted to be able to bring to you the talent that we have in our own hospital, also from MGH, hear from the experts, get the information, ask the questions, take it back, tell your friends. And so it's really important. So again, I want to thank each and every one. I also want to thank our own local team of Ugna and Gretchen. They helped my husband and I through his cancer journey, right through palliative, right to hospice, and I can't thank you enough. I really appreciate it. Well, do I do the slide? The next slide? It's our privilege right now, this evening, to honor Sarah Newton. She's a dear friend, and we're dedicating this Woman in Wellness 2021 to Sarah. She, as you know, is a dynamic, she's compassionate, and she supported our hospital for many, many years. We always remember how Sarah was quick to say yes. Yep, I'm in. I'll help you. She would take up any meaningful opportunity and drive it right to the end. Her resources, obviously her background, and this beautiful woman with her husband, Jeff, always intentional about her work, always looking for the strongest outcomes, and always, always with just unbridled enthusiasm. So you look at Sarah and her husband, and they were champions of our hospital. For as long as I've known her, and many of you here are very close friends with her, she and Jeff were co-chairs of POPs, and that's when we had the rendition of Rain, the Beatles, and Did It Rain. If you can remember, we all threw our ponchos on, and Sarah was the first one out there dancing. And so we all did. Everyone got up and danced in the rain, and it was fabulous. She was an active member of our marketing and development committee, always big ideas, always with reference, because she was involved all over the country in different nonprofits, not just here. So we always got the best of her. And then she chaired last year our first virtual COVID in the heart of the peak of COVID, because that's just Sarah. That's our girl. That's what she did. She accomplished all of this with that twinkle in her eye, smile on her face, and again, with that fabulous enthusiasm. You're going to love when you hear this. Jeff shared their story of when they met at Wharton. So Sarah brought Jeff to meet her mom. And she said, "Mom, I'd like you to meet my colleague, Jeff Newton." When he left, she said, "Sarah, that man's in love with you." Indeed, he was, because after their first date, 4 months later, he asked her for his hand in marriage. So I thought that was really beautiful. Love of each other's lives. And can I just ask you to do this? Right now, Sarah is present. This is dedicated to her. Can we say, God bless Sarah? Let's stand up and let's give her a beautiful round of applause, because she's looking down on us right now. I can tell you that right now. Thank you. All right, we have a bunch of Zoomers on here, and I'd love you to be able to chat with us. We have Elizabeth Miller, we have Ellen Hofeld, we've got Carol Heaton, Arlene O'Reilly, a whole bunch of women. So they're on Zoom, which was great that we kicked that in right after we had to move to masks, etc. So we want them to participate as well. Let's celebrate your success. Do you remember year before last, when we wanted to raise money and asked you to invest in the Labyrinth Garden? And that was underway, and we all thought that was a magnificent thing for Women in Wellness to do. And we did. You raised over $70,000. And we did that in honor of Margot Hartman, who had been in the ER and been our CEO, I think, for 18 plus years. And so we recognized her for that. And if you remember, if you were all here, we gave her that big bouquet of flowers, and she just was so thrilled. So if you ever get an opportunity, it's on our campus. Go over there and take a look. I know a lot of people haven't seen it, but when you look at Labyrinth, it represents a journey to our own center and back again into the world. And I think that's kind of a beautiful thing. All right, you heard something very important today. And you heard about cold caps. I'm gonna tell you a story. And this story is about Meryl, right here in the front. She said it's okay if I did this. She had the lung cancer, as you all know. She lost her hair. She has a lot of hair. And as she said, it took a long time for that hair to grow back. Didn't have a cold cap for you at that point. She got it again. She lost her hair. So when you think about this technology, ladies, and the need that we have, it's significant. And each and every one of us together can lift a woman up. And there are women in our community right now that need it, can't afford it, insurance doesn't cover it. So that's why you have the 8%. 8% of women, can you imagine? Because of the dignity, because of what you went through as far as the self-body, you know what I mean. You know what I'm saying. That women choose not to do it. Well, we don't want that to happen. That absolutely can't happen, right? It just can't happen. So if we're able to sidestep the hair loss, sidestep during the most difficult time of your life when you're going through cancer, to keep your hair and look pretty and feel good about yourself and go to work. And I loved what you just said about children being traumatized when they see their mom losing her hair. I never even thought of that, of course. So what we can do is change some lives here, very big. So this has been going on the last 18 months. We've got the need. It costs $2,200, as I mentioned to you. And what I'd like to ask you at this moment is there in this group at this moment, let's think about starting a cold cap fund for Nantucket Cottage Hospital. And so what I'm going to ask you to do is to think about investing in it. And if we can get this group
collaboratively to invest, and I'm going to be asking you to raise your hand like I did for the labyrinth, and you have pledge cards in your program. Think about it for a moment. One woman came up to me last time. We're about to go upstairs, and we're going to enjoy ourselves when we're networking and chit-chatting and everything else. But what I wanted to say is a woman came up to me, and she said, you know, I've never been to Nantucket before in my life. And she said, and I just invested $1,000 in this labyrinth garden. She said, I was so motivated by the spirit of everybody that was in this great, beautiful hall that we're in. So ladies, are there any women right now that would like to invest in this fund so the next woman that comes to our hospital and has financial needs says, I'm going to go ahead and do it because I can do a cold cap? Are there any women that will invest $1,000 right now to be part of this collective movement? Ladies? Any other women? Zoomers? Chat. If you want to do it, would you please chat? Thank you. Any other? Thank you. Raise your hands. It's inspiring to see everybody. Thank you so much. And this gentleman right here, he did too. Thank you. Now, how about if the $1,000 might be too big of a reach at this point for you, how about $500? How many of you right now would raise your hand and do $500 to invest in our cold cap fund? Thank you, Meryl. Anybody else? Anyone else? $500 in the back here, wonderful. How about $250? Anybody in this room? $250, thank you very much. Please raise your hands high. And you please chat on Zoomers. We want to see you participating too. That is absolutely wonderful. Okay, so, thank you. That is absolutely wonderful. Thank you. You know, the power of women, you can never underestimate, and men, when we collectively look at something with great passion and commitment, say, we're going to make a difference. And you just did. If you want to think about it a little bit, have a glass of wine, you just might be filling out this card, you know? I don't know. Maybe 2 glasses.
So you didn't go high enough when you started out.
Oh.
So I think you should have somebody have $2,200, and I'd like to buy one.
Oh, Gary. All right. And if you did 1,000, if you'd like to back off from that and buy a cold cap for $2,200? Oh, Robin. Okay. Fantastic. Anybody else? Oh my gosh. Yeah. All right. Who is that? Susan. Is that Susan? Oh my God. Okay. There's another cold cap. Do you know what? Can we have their names on the cold caps? With the names? That'd be cool. Wouldn't it? That'd be very cool. That is really, anybody else, believe me, just look at your pledge form, see how you feel. We're going to go upstairs right now. You can talk to all of our panelists. You can grab Gary. You can talk to Gary. But here's what I just want to conclude with. Thank you, Meryl. Thank you, co-chairs, because you can't say thank you enough, all right? Really, you can't. Karen and Mary and our entire committee, raise your hands. Robin, everybody raise your hands. Manu, that's our committee. Our sponsors, the NCH staff, led by Chris, lean and mean. They make it happen. They get it done. And Gary Shaw, thank you. Took 18 months to find you, but we found the right man. He's keeping our community safe with the whole NCH team. 24/7 they work. $2 million additional expense for COVID. That's what we did to keep this community safe. And don't forget POPs. It's happening. It may not. We're bringing POPs to you from Jetty's Beach to your home. 8 o'clock on the 14th. And Gary will be in it. I'm going to be with David Gregory, and we're having the best of POPs. We're playing all of our great songs, all of our great people. So please buy your tickets. Go online. Really, it'd be fantastic. And then I also like to thank the team here at the Dreamland. You went over and above. They've done one heck of a job. All right, ladies, let's go upstairs. Let's network, and let's enjoy one another. And thank you all for coming.